Welcome, curious minds, to another deep dive. Today, we're zeroing in on a topic absolutely central to healthcare, one that impacts millions and really defines so much of what nurses do every single day. We're taking a deep dive into the world of chronic illness, drawing insights from, the fundamentals of nursing, the 11th edition by Potter, Perry, Stockert, and Hall. Our mission, it's really to distill the most vital nursing concepts, think patient care principles, clinical judgment, ethical considerations, and make them super clear for you, our dedicated nursing students, getting you ready for those real-world scenarios.
That's exactly right. We're going to unpack the complexities of chronic conditions, focusing on how these ideas translate directly into practice. In hospitals, communities, even home care, we'll talk through key charts and diagrams, try to demystify some of that medical jargon, and importantly, connect it all back to NCLEX competencies and best practices.
Yeah, get ready for those aha moments, hopefully. We're aiming to turn what can feel like dense material into something engaging and, well, actionable.
Yeah. Okay, let's unpack this. So let's start at the beginning because chronic disease and chronic illness, they get used interchangeably a lot, right? But for nurses, there's a really important distinction we need to make.
Oh, absolutely. It's crucial for how we approach care. Chronic disease, that's the medical diagnosis,
Right.
the actual pathophysiologic condition. Think of it like the label. It lasts over a year, needs ongoing medical care, and often limits what someone can do day to day.
Right. And chronic illness, then, is more about the person's experience.
Exactly. Chronic illness is all about the patient's and their family's subjective experience, how they respond to that disease. So let's take Maria. Maybe she's 55, living with type 2 diabetes. The disease is diabetes mellitus. That's the diagnosis. But the illness, well, that's her daily reality. Managing her diet, juggling medications, the blood sugar checks, the emotional weight of it all, the lifestyle shifts. It's her unique journey with that diagnosis. That distinction really frames the holistic view nurses need. And thinking about Maria, she's definitely not alone. The stats on chronic illness are, well, pretty staggering.
They really are. They put things into perspective fast. In the U.S., 6 out of 10 adults have at least one chronic disease. 6 out of 10.
Wow.
And get this, 4 out of 10 are managing 2 or more. So, think about the people you interact with every day. Most likely, they're managing something chronic. It's not niche, it's become the norm, and it fundamentally changes how we need to think about healthcare.
And the cost associated with that must just be enormous.
It really is. The CDC estimates something like 90% of the nearly $4 trillion spent on healthcare in the U.S. goes towards chronic and mental health conditions.
90%.
Yeah. Just to give you a sense of scale, if we look at Table 8.2 in the book, it mentions things like cancer care hitting $174 billion annually, heart disease and stroke, about $214 billion, dementia, over $300 billion. And for individuals, like someone with diabetes, it averages over $16,000 per year. That's like 2.3 times higher than someone without it. These numbers aren't just abstract figures. They show why prevention and good management are so critical economically, too.
Wow, those figures really hammer home the need for prevention and effective management. So, okay, with impacts this huge, what's actually driving this prevalence? It's rarely just one simple cause, is it?
You're absolutely right. It's multifactorial, almost never just one thing. It's usually this complex interplay of genetics, environmental factors, and lifestyle choices. The book uses figure 8.1, which is help imagine a central point labeled risk for disease. Then picture 3 big arrows pointing at it. One says environmental factors, one genetics, and one interactions. It visually shows how these things kind of weave together to increase the risk. Every patient is unique because of how these factors mix.
That visual helps clarify it. Now, genetics. People often think, oh, it's in my genes, it's destiny. But how do we, as nurses, explain that it's often more nuanced than that? That having a gene doesn't automatically mean you will get the disease.
That's such a key point to communicate. Yes, some conditions, like Huntington's chorea, have a clear autosomal dominant pattern, a 50% risk if one parent is affected. Or cystic fibrosis, autosomal recessive, a 25% risk if both parents are carriers. But these single gene disorders are actually a small fraction of chronic diseases.
Right.
Most common chronic illnesses, diabetes, heart disease. Many cancers, they result from what's called multifactorial inheritance. It's a mix of genetic predispositions interacting with your environment and your lifestyle.
Okay.
So genetic testing, say for BRCA1 or BRCA2 mutations related to breast cancer risk, it tells you about increased risk. Doesn't guarantee you'll get cancer. It's information for making informed choices about screening or prevention.
Gotcha. It's about empowering choices.
Right.
Okay, what about the environmental side of things? How significant is that piece?
Oh, it's huge. Unhealthy environments contribute to millions of deaths globally each year. Think about ongoing exposure to air pollution, contaminated water, pesticides, asbestos, mold, heavy metals. These significantly raise the risk for respiratory diseases, heart problems, certain cancers. A specific example mentioned is childhood-lead exposure in the U.S. The estimated cost is around $84 billion a year because of its long-term health and developmental impacts.
Wow.
So the nurse's role here is vital. We do risk assessments, we educate patients about these common exposures, and we empower them to minimize contact and advocate for safer living and working conditions.
And then there are the factors we arguably have the most influence over, lifestyle and those modifiable risk factors. This seems like a huge area for nursing intervention.
Absolutely. This is where we can potentially make a massive difference. The most common modifiable risks are things like smoking, poor nutrition, drinking too much alcohol, and not getting enough physical activity. Smoking, for example, is still the #1 cause of preventable death in the U.S., linked to, I think, 16 types of cancer. And the potential savings, if people stopped smoking, are enormous, like $170 billion a year. Plus, we're seeing this concerning rise in e-cigarette use among teens now, too.
Yeah, that's worrying. And alcohol and diet play big roles too.
Definitely. Excessive alcohol use is linked to about 1 in 10 deaths among working-age adults. Huge costs there, too, around $249 billion annually. It ups the risk for heart disease, liver disease, several cancers, and then nutrition and physical inactivity. About half of U.S. adults have preventable chronic diseases related to those. The book has Table 8.3, which outlines strategies things like increasing physical activity and cutting back on high-fat, high-sugar foods to prevent obesity, staying active and managing weight to prevent type 2 diabetes, dietary changes for cardiovascular health, limiting alcohol and maintaining a healthy weight to reduce cancer risk. Simple things, but powerful. Calcium, vitamin D, activity for osteoporosis, fluoride, and less sugar for dental health. These are concrete actions nurses guide patients towards.
Those stats paint the big picture, but the day-to-day reality must feel very different for the person living with it. When you mention things like chemo brain or needing oxygen, what's a common misconception people might have about those physical limitations, especially the invisible ones?
That's a really good question. A common misconception is often summed up as, well, you look fine. People assume if the struggle isn't immediately visible, it must not be that bad. But the physical effects vary incredibly. A cancer survivor might deal with peripheral neuropathy, that's nerve pain or numbness, or cognitive issues like chemo brain, which can linger for years. Someone with severe emphysema might rely on oxygen, have physical signs like clubbed fingers or a barrel chest, and face challenges with malnutrition or just getting around. It underscores why care must be individualized. No two people experience the same disease in exactly the same way.
And it's clearly not just physical. The psychosocial impact seems immense.
It really is. Chronic illness ripples through every single aspect of life. Economic stability, functional ability, work, psychological well-being, sexuality, social connections, even spirituality. How someone perceives and copes with their illness, what the text calls their illness representation, is deeply personal. Let's go back to Maria with diabetes. If she develops a new symptom, say foot pain, her mind might instantly jump to amputation, suffering, loss of independence, triggering intense anxiety.
Yeah.
Nurses have to critically assess that unique perspective to offer genuinely patient-centered care.
And we often see comorbidity, right? Physical and mental health issues tangled together.
Precisely. They very often coexist. And medications for one condition can sometimes worsen the other. Depression, for example, is incredibly common in people with chronic conditions. It can stem from frustration, fear, losing a sense of control, and it makes everything harder. It often leads to increased pain perception, more fatigue, social withdrawal, and crucially, it can really sabotage treatment adherence.
And that social isolation piece, you hear, it can be really detrimental.
It absolutely can. There's research suggesting loneliness and social isolation are potentially twice as harmful to physical health as obesity. As an illness progresses, or if symptoms are embarrassing, people might withdraw. Think about the case scenario described. Two 75-year-old women, both with heart failure. One lives alone, feels isolated, struggles with their diet and meds, maybe blames herself. The other is married, has strong social support, sticks to her plan, feels more positive. It's a stark illustration of how connection impacts self-management and outlook. So nurses really need to assess for loneliness and make sure intimacy needs are addressed, whatever that means for the patient.
So faced with all this, how do people cope? What strengths do they draw on? And how can nurses help foster those?
Well, patients tap into both internal and external strengths. Internally, you see things like persistence, trying to maintain a positive outlook, insight, just sheer courage sometimes. Externally, it's the support systems, family, friends, supportive healthcare providers. And then there are self-management strategies. Staying active in ways they can, planning ahead, finding ways to manage stress, setting achievable goals, seeking out information. As nurses, we can help identify these strengths, encourage patients to find enjoyable activities. Maybe it's gardening, maybe it's video calls with grandkids if they're far away. Anything to stay connected and feel a sense of purpose. Bolstering those existing strengths is key.
And of course, chronic illness looks different across the lifespan, children versus older adults.
Yes, absolutely. For kids with chronic conditions, there's a higher risk of depression or anxiety later on. It can impact school, friendships, and siblings feel it too. They often need support as well. So the approach must be family-centered, empathetic, involving the whole interprofessional team. For older adults, the focus often shifts more towards managing symptoms, maintaining comfort, preventing crises. They might grapple with feelings of powerlessness, depression related to body image changes, limitations in self-care, loss. So assessment for depression is crucial, as understanding their perception of aging. Collaborating with PT and OT to maximize function and independence is really vital.
It's clear it's not just the patient in isolation. The whole support system, especially family caregivers, plays a huge role. How are they impacted, and what's our role in supporting them?
Family caregivers are, well, they're often the invisible backbone of chronic care. We're talking over 1 in 6 working Americans who are juggling their job with caring for a family member or friend with a chronic illness or disability. It's incredibly demanding time-wise, emotionally, socially, financially, physically. Caregivers frequently neglect their own health because they're so focused on the person they're caring for. This leads to caregiver burden.
What makes that burden worse?
Certain factors increase the risk for poor outcomes for the caregiver. If they've been providing care for more than a year, if the caregiver themselves is over 65, if the patient has very high needs, if the caregiver feels they lack resources like knowledge, skills, or social support, or if they're caring for someone with dementia. Living with the care recipient also adds to the strain.
So what can nurses do?
Our role is multifaceted. We need to assess the caregiver's health and their own responsibilities. Build that therapeutic relationship with them too, not just the patient. Assess the physical, psychosocial, financial toll it's taking on them. Connect them with resources, respite care, support groups, social work, counseling. Provide education not just about the patient's condition, but about self-care for the caregiver. And absolutely include them as part of the interprofessional care team. They have invaluable insights.
This whole picture is so complex, it makes sense that we need a framework to guide how healthcare approaches this. And that's where the chronic care model, the CCM, fits in.
Exactly. The CCM provides a really solid framework for organizing and delivering healthcare for chronic conditions. Figure 8.2 in the text gives a good visual. Imagine it like this. At the very heart are the informed, activated patient and the prepared, proactive practice team. These two are having productive interactions. The goal of these interactions is improved outcomes. Now, surrounding this core interaction are 2 bigger circles. One is community, representing resources and policies available outside the clinic. The other is health systems, which is about how healthcare itself is organized. And under that health systems umbrella, there are key components: self-management support, delivery system design, decision support, and clinical information systems. It ties it all together.
So it's really holistic, connecting individual care with the community and the system itself. What are the core elements nurses really need to grasp from this model?
There are 6 essential elements. First, community. This involves partnerships beyond the clinic walls, working with community organizations, pushing for public policy changes like smoke-free laws or taxes on unhealthy products. Nurses can be advocates here. Second, self-management support. This is huge. It's about collaborating with patients, empowering them to manage their condition. Some studies suggest this is actually the most effective part of the model for improving outcomes.
Makes sense. What are the other 4?
Okay. Third is the health system itself, focusing on continuous quality improvement in chronic care, safety, efficiency. Fourth, delivery system design, making sure care is evidence-based, patient-centered, and works across different settings, from the hospital to outpatient clinics to home. Fifth is decision support. This means providers using the best current evidence-based guidelines and educating patients so they can participate in decisions. And sixth, clinical information systems, having good systems to track patient data, share information between providers, coordinate care, basically. You can see how these elements work together to improve coordination, follow-up, education.
Yeah, you can definitely see the logic. It seems like a much more integrated approach. Okay, let's bring this down to the bedside or the clinic room. What does all this mean for nursing in action? How do nurses apply these ideas day to day?
Nurses are absolutely central to making this work. Our role starts with promoting healthy lifestyles and detecting risks early on. But given the complexity, it requires really thorough assessment skills and sharp clinical judgment. A huge part of the job is helping patients and their families learn to manage the illness effectively, providing that crucial education. Figure 8.3 paints a picture of the nurse's role in prevention. It shows screening for early disease, supporting public policy, increasing healthy behavior through education, and genetic testing and family history assessment, all feeding into prevention of chronic disease. We're involved in all those areas.
When we're doing that assessment for someone already living with a chronic illness, you mentioned how unique each experience is. What's the best way to really hear their story to get that full picture?
Listening is key. The power of the patient's story can't be overstated. Use open-ended questions. Instead of just rattling off a checklist, ask things like, can you tell me more about how that started? Or what's the biggest challenge your condition causes you right now? Or how does this illness affect you most days? These invite sharing. Table 8.4 gives examples asking about symptoms like pain, sleep, appetite, how they're coping, adherence issues, but also digging into psychosocial aspects. How is the family responding? How does the illness affect their self-image? Any changes in intimacy? And importantly, asking about financial barriers. Creating that respectful, caring space encourages people to open up.
That makes sense. Now, one of the toughest parts of chronic care is often adherence, right? Getting patients to stick to sometimes complex plans. Why is non-adherence such a persistent problem, and what are we doing about it?
Oh, it's a massive challenge. Non-adherence leads directly to more hospital visits, worse health outcomes, and costs the healthcare system hundreds of billions, maybe $100 to $300 billion annually. It's huge. And the reasons are varied. Sometimes it's the severity or how long they've had the illness. Sometimes it's just how complicated the treatment is. Multiple meds, specific timing, diet changes. Socioeconomic factors play a big role too, like cost or access. And then there are patient characteristics, motivation, beliefs about the illness or treatment, health literacy, mental health status. Even just accessing the healthcare system can be a barrier.
Right. It's rarely just one thing, like the patient not wanting to do it.
Exactly. I remember a patient, super motivated, really wanted to manage his heart failure, but his medication list was just overwhelming. Multiple pills, different times of day, some with food, some without. It wasn't lack of will, it was the sheer complexity and burden.
That really illustrates the challenge. So what evidence-based strategies actually work to help patients like him adhere better? Box 8.1 mentions some.
Yes, Box 8.1 highlights several effective strategies. Interprofessional approaches are key think health coaches, or the patient-centered medical home, PCMH model, which uses a team approach. Strong social support is vital, so involving family helps. Actively assessing for barriers is crucial. Is it cost? Is it the number of pills? Is the family dynamic hindering things? And then using techniques like motivational interviewing, that's a specific counseling style, to help patients work through ambivalence and find their own motivation for change. We also use tools like the Adherence in Chronic Diseases Scale, the ACDS. It's a quick 7-item questionnaire, mostly about meds, or even simple things like patient diaries or reviewing meal plans together to gauge adherence and problem solve.
Beyond just taking meds, managing ongoing symptoms is a big part of living with chronic illness.
It absolutely is. We need to explore symptoms thoroughly. If Maria mentions that foot pain, the peripheral neuropathy from her diabetes, we need to ask, how bad is it? What makes it worse? Is it affecting your sleep, your balance, your ability to feel things properly? We also do targeted assessments. For tobacco use, how much? How often? Secondhand smoke exposure. Do they understand the risks? Are they even thinking about quitting? For alcohol, how much do they typically drink? We use screening tools like the ATIT, that's a 10-item questionnaire to check for misuse, which is generally defined as more than 4 drinks a day or 14 a week for men, or more than 3 a day or 7 a week for women. And we need to explore the broader lifestyle impacts, psychological, social, spiritual, sexual needs. How does the illness affect their daily routines, self-care, hobbies, meals, sleep? Observing interactions can also give clues.
And all of this really connects back to the larger goals of health promotion and disease prevention.
Exactly. That's a core nursing function. Patient education is central here, but its effectiveness depends on the patient's motivation, their readiness to learn, their ability to process the information. We need to tailor it. Figure 8.4 highlights the WHO recommendations for preventing chronic, non-communicable diseases. We touched on these. Physical activity goals, 150-300 min-week moderate for adults, 60 min-day moderate vigorous for kids, balance exercises for older adults, strength training for all, diet recommendations, limit sugar, fat, sodium, boost foods, FEG, aim for healthy weight, limiting alcohol, avoiding tobacco. These are the pillars.
Are there specific resources or screening practices nursing students should definitely know about?
For sure. For helping patients quit smoking, resources like the American Lung Association's Freedom from Smoking program are great. For alcohol information and support, the CDC and NIAA websites are reliable. And screenings are non-negotiable for prevention and early detection. Regular blood pressure checks, monitoring height and weight in kids, age-appropriate cancer screenings, breast, colon, cervical, prostate. Catching things early drastically improves outcomes. And for genetic screening, while we might provide basic info and take family histories, it's usually best to refer patients to genetic counselors or reliable online resources like the Genetics Home Reference website for specialized guidance.
Okay, this leads us nicely into empowering patients for self-management. That seems like the real key to future chronic care.
It absolutely is. Patient education and effective chronic disease self-management are crucial for helping people live well despite their illness and reducing those costly hospitalizations. Nurses are really pivotal in improving care at home. We need good communication tools. The AHRQ Health Literacy Universal Precautions Toolkit has great strategies for making information clear and understandable. Using the teach-back method, asking patients to explain things back in their own words, is essential to confirm they've really grasped it, and it's a team sport. Figure 8.5 shows that image of nurses, pharmacists, dietitians, doctors, all working with the patient. That interprofessional collaboration is vital.
And we keep coming back to adherence, but it's so critical. What other creative strategies help?
It's an ongoing effort. Besides motivational interviewing and education, things like coaching, simple reminders, text messages can work wonders, helping establish routines, simplifying the treatment plan whenever possible, acting as a patient advocate when navigating the system, really engaging in shared decision-making so the patient feels ownership, and consistent follow-up are all part of the toolkit. It's about finding what works for that individual.
Can you tell us more about those self-management education programs you mentioned, like the CDSMRP? They sounded really promising.
They really are effective. The Chronic Disease Self-Management Resource Program, developed by Kate Lorig at Stanford, is a well-known example. It's typically delivered in small interactive group workshops, maybe 2.5 hours once a week for 6 weeks, often held right in the community, like at a library or church. A key feature is that they're often led by trained peer leaders, people who also live with chronic health conditions. That shared experience builds incredible trust and rapport.
What do they actually learn in these workshops?
The content covers general disease information, but focuses heavily on practical skills. Action planning, making informed decisions, problem solving around challenges. Participants set their own achievable weekly goals. The evidence shows these programs lead to improved health status, better self-efficacy, and people actually use fewer healthcare resources afterwards.
That sounds fantastic. What are the main hurdles for patients getting into these programs, and how can nurses help?
Sometimes it's just awareness, people don't know they exist. Other times it's practical things like transportation or time off work. Nurses play a huge role in referring patients, especially those juggling multiple conditions, and helping troubleshoot those barriers. The programs teach skills for managing fatigue, pain, difficult emotions like isolation, sometimes practical things like gait training, how to manage medications effectively, and how to communicate better with doctors and family. Besides structured programs, Table 8.5 lists great websites, reliable sources like the American Heart Association, American Cancer Society, American Diabetes Association. Many offer digital tools for tracking or self-assessment too.
And looping back to the chronic care model, there's that public policy piece. What's the nurse's responsibility there?
It's part of our professional duty to advocate for public health. This means staying informed about and supporting policies that address those environmental and societal factors contributing to chronic disease, things like clean air regulations, access to healthy foods, smoke-free spaces. Advocating for policies that reduce the overall burden of chronic illness is an extension of advocating for our individual patients.
This has been incredibly insightful. We've really covered the landscape of chronic illness, from definitions and the sheer scale of its prevalence and cost to the really intricate mix of genetic, environmental, and lifestyle factors involved.
We have. And we've delved into the profound physical and psychosocial impact on patients and their families, highlighting the absolutely crucial role nurses play in careful assessment, promoting adherence, and empowering patients through education and support.
And here's what I find really exciting. When you grasp the chronic care model and you actively work towards supporting self-management and advocating for sound public health policies, you're not just tweaking individual outcomes, you're actually helping to reshape the entire future of healthcare delivery, moving it from purely reactive to much more proactive.
Which leads to a really important question for you, our listeners, as you move forward in your careers. How will you take this comprehensive understanding of chronic illness and not only provide excellent care for those already living with these conditions, but also step up as powerful advocates for prevention and health promotion within your own communities?
That's definitely something to mull over. We sincerely hope this deep dive has equipped you with valuable insights and practical knowledge for your nursing journey ahead.
Thank you so much for joining us today, for being part of this learning journey with us. We really appreciate you being part of our community.
Until next time, keep exploring, keep asking questions, and keep making that vital difference.